A 36-year-old female presents with acute neck pain, stiffness, and severe pain with swallowing. I am showing you lateral and cone-down radiographs of the cervical spine. Please describe the findings.
The lateral radiograph demonstrates significant prevertebral soft tissue swelling in the upper cervical spine from the C1 to C3 level. There is a smooth, amorphous, ovoid calcific density located anterior to the C2 vertebral body.
What is your primary diagnosis?
The findings of retropharyngeal prevertebral soft tissue swelling and amorphous calcification anterior to the C2 vertebral body are diagnostic of acute retropharyngeal calcific tendinitis, secondary to calcium hydroxyapatite deposition disease, or HADD, of the longus colli muscle.
What is the typical clinical presentation, and what serious condition does it commonly mimic?
It typically presents with acute neck pain, neck stiffness, and painful swallowing. It is a critical mimic of a retropharyngeal or prevertebral abscess.
Where specifically does the calcification occur within the longus colli muscle?
The calcification classically occurs within the superior oblique tendon fibers of the longus colli muscle, at their insertion on the anterior tubercle of the C1 vertebra or anterior body of C2.
Why is it clinically vital to recognize this benign condition on imaging?
Recognizing this condition avoids unnecessary invasive surgical intervention, such as incision and drainage, which would be indicated for a prevertebral abscess.
What is the expected natural history of this condition, and what would follow-up imaging show?
This is a benign, self-limiting condition. Follow-up radiographs after several weeks or months typically demonstrate complete resorption of the calcification and resolution of the prevertebral swelling.
Which other joints or tendons in the body are more commonly affected by calcium hydroxyapatite deposition disease?
HADD is far more common in the shoulder, particularly involving the supraspinatus tendon of the rotator cuff, and in the hip, involving the gluteus medius insertion.
Finally, what are your clinical management recommendations?
I recommend conservative treatment with nonsteroidal anti-inflammatory drugs and analgesics. I also suggest a follow-up lateral radiograph in a few weeks to document resolution and confirm the diagnosis.